Long grief
Oh,
disorder.
okay, so-
Oh, and it's definitely been longer than 6 months.
Yeah, yeah. Yeah, so persisting complex bereavement disorder or bereavement. Is it reasonable to assume that Edith's initial response was bereavement? Especially if we took this out of the horror genre and made it a drama. Somebody tell me, again, already preparing for a shelf exam, initial thoughts on bereavement. What are you looking for? What do you expect? How would you identify it on a shelf?
I think it's like beyond the accepted / normal amount of grief and sadness. And it extends, and I think the duration is like longer than 6 months.
Or
Persistent bereavement.
so let's look at bereavement first.
Oh, sorry.
Then, no worries, then it make it that much easier. You're right. So I'm gonna answer the question again in about 20 seconds.
Okay.
Bereavement, what do we have about bereavement? Yeah. I think, psychologists will often point to grief being the emotion or feeling bereavement syndrome, but, we all, clinicians interchange those terms. The bottom line is that bereavement is normal, right? It's a normal grief reaction. Being normal and therefore not disordered, it will not, by definition, it will not result in clinically significant distress or impairment. That's bereavement. Persistent complex bereavement disorder is when bereavement is disordered, when it does actually result in clinical distress. Right? The American Psychiatric Association is getting away from the actual timelines, realizing that, we thought 2 months was a cutoff. The medical literature certainly doesn't support that anymore. So they're at a point where we're looking at things qualitatively instead of quantitatively. And that's going to be teased out, I think, in the next revision that we accept. Right? What evidence exists that Edith Brennan does not have persistent complex bereavement disorder? It happens to her.
Like all the way to the end, considering like she kind of abandons like the actual thing that she had been seeing for the whole time for like the new child. She kind of.
And in the flashback, what happens to her and her baby? Why is she a ghost?
She jumps off the cliff, but
Yeah.
she commits suicide and kills her baby at the same time.
Yeah.
But her issue is what happens to her baby, apparently. Cause I
Post-mortem.
believe, right,
Right. Yeah, I mean, there is infanticide and suicide as major themes to this movie. Major issues in the field of psychiatry suggest that Edith Brennan's primary diagnosis probably evolved to a major depressive episode, and a severe one at that. So I'm not so sure I'd be so comfortable choosing persistent complex bereavement disorder on a shelf exam when major depressive disorder would also be included in that answer set. Now again, we're filling in the gaps. We don't have a chance to talk to Edith, whether it's during her time at the asylum, at that inpatient facility, or even afterwards as mama. I think as a clinician, that's where we focus. That progression from bereavement to persistent complex bereavement disorder to a major depressive disorder. Is there any more to this? Is there any other teaching points to make about the case of Edith Brennan?
well, I like the fact that she was able to move on and take and place that baby with Lily, cause she got what she wanted. You would think usually at the end of a movie like that, she would take her baby and be happy, like Moana, in that sense. But she actually takes Lily with her and is happy with that, and Lily's happy with that. And Lily has an attachment to her that is, I would say she has a parental normal attachment with this person who has cared for her for 5 years.
So she definitely has an attachment. We can look at this movie and view this film through both of those sisters' perspective. And certainly Lily being young when she was initially abandoned would be in that window of period where we're thinking attachment and bonding and why the movie ends the way it does and how it ends. Unfortunately, that's as far as I go with regard to clinical psychology or child adolescent psychiatry. That's just not my background. But maternal bonding certainly is a major theme here as well, and primarily focused on Lily. And you know, similarly, conversely, why it doesn't happen with Victoria in terms of her age. Refocusing on Edith, there might be another point or two to make here, though. One I think is the observation, perhaps not necessarily explicit, but that she demonstrated symptoms prior to her delivery. Right, she gave birth to her baby in the hospital. There was a reason why she was admitted there in the first place. Right, now, there's no history given there other than the fact that for Victoria, she was sad, right? So, yeah, a mood disorder, if not a depressive disorder. But when we look at what happens in this movie, and we see the infant side, might there be other conclusions? Might this be teased out even more? What, in addition to peripartum depression, should the clinician consider in Edith's case? Postpartum, yeah. That's something to be strongly considered here. And if so, and I'm not sure we have any more information than what we've already discussed, then the reason why she was hospitalized, the reason why she was sad is likely due to what condition? What underlying mental disorder is thought to manifest, precipitate as a result of the labor or the act of childbirth, resulting in postpartum psychosis?
I think we talked about this more in bipolar disorder.
And I think the case of Edith Brennan actually fits the idea in the discussion of bipolar disorder.
Is the thought there that like it's such a traumatic thing for some people giving birth that could like unearth an underlying psychotic issue?
Yep. You basically get the gene expression of what we know or as manifest, typically expressed as bipolar. And again, the idea that she was initially hospitalized because, quote unquote, she was sad is consistent with that, right? Most people actually present with a depressive episode for bipolar 1. Okay. All right, so let's talk a little bit about bipolar and how if Edith Brennan were treated in 2024, things may have turned out different for her. All right, so first, let's actually get an idea of what is referred to when we discuss the bipolar and related disorders. Bipolar 1. How do you diagnose it?
Presence of at least one manic episode.
Yep, stop right there. That's it. That's all you need to know, right? If an individual has a manic episode, and implicit in that is that their mania is not induced by a substance or an underlying medical condition, right? You're telling me manic episode, you're telling me implicitly that it is not substance induced or the result of another medical condition. Right? 9.9 times out of 10, the individual with a previous or a single manic episode has bipolar 1. What is that other 0.1? What is the only other mental disorder that could be taking place here? The point prevalence of which is less than 1%.
Schizoaffective?
Good. Right. Schizoaffective disorder of bipolar type is the only mental disorder that can be diagnosed other than bipolar 1 in someone with a manic episode. That could be Edith Brennan, not sure it is. Right, I think my clinical focus would really be on bipolar 1 here. Right. How does bipolar 1 differ from bipolar 2? Good. Right. And if bipolar 2 differentiates from bipolar 1 by evidence of a hypomanic episode, the follow-up question is, how does hypomania differ from mania?
It's not like a loss of functioning.
Good. Right. So if you're looking at the signs and symptoms, they're exactly the same. So if you've learned what an episode of mania is or looks like through DIGFAST, DIGFAST, God bless you, is also the acronym to remember a hypomanic episode as well. Hypomanic episodes, both quantitatively, does not reach that 7-day threshold, and qualitatively is by definition not clinically significant. You don't hear that much in psychiatry. Almost everything we focus on behaviorally in terms of disorders is a disorder because it does in fact result in clinical significance. Here we have a syndrome, hypomania, that is literally defined as avoiding that very criterion. How do all of the above, either of these, differ from cyclothymic disorder?
I believe the major difference in episodes required for diagnosis of bipolar 2, but cyclothymia only has like minor depression going up to hypomania.
So when you pair this hypomanic episode, not with a major depressive episode resulting in a provisional diagnosis of bipolar 2, but instead with a minor depressive episode, signs and symptoms of depression that again, qualitatively and quantitatively do not reach a major depressive episode threshold. We call that minor depression. And that paired with hypomania provides us a diagnosis of cyclothymic disorder. Cyclothymic disorder, similar to dysthymic disorder, persisting depressive disorder as of 2013, is chronic, meaning that it must be 2 or more years, and the individual does not go more than 2 months without symptoms. Right, so it's chronic and persistent. Right. Any questions about the bipolar and related disorders, specifically bipolar 1, bipolar 2, cyclothymic disorder, and the related syndromes, mania, hypomania, major depressive episode, and minor depression?
Where is like an adjustment disorder?
Adjustment disorder is when an individual demonstrates depressed mood without any other SIGI caps.
Okay.
That is for which a cause and effect is established. Right, so now I'm going to ping pong this back in the form of a question. Cause and effect is operationalized by the American Psychiatric Association. How? It's the operational definition per the APA for cause and effect. Symptoms must have their onset within 3 months of an identified stressor. So if you came to me and said, hey, Dr. T, I feel down, and I ask what's going on, and you say, well, yeah, I'm matriculated to medical school. And I say, yeah, when did that take place? So about 3 years ago. Yeah. Right. Similarly, if you did though, or if we have an M1 that says, yes, it's October, and as fun as October is and how great I should be feeling, I'm feeling down because within the past 3 months, I've matriculated to this new school. The second part of the definition is that when the stressor is alleviated, so too do the symptoms, and that's within 6 months. Right, so that 3-month and 6-month window allows us to operationalize cause and effect. And that's an adjustment disorder. An adjustment disorder can actually present with depression, anxiety, both, that is mixed emotions, a disturbance of conduct, or all of the above. Right, mixed emotions and disturbance of conduct. That answer your question?
That factor into the second time.
I don't think, in clinical practice, it's gonna confound. But again, we'll kind of try to artificially create these two columns where one, we call it an adjustment disorder because we have an identified stressor and we see a resultant depression and or anxiety and or disturbance of conduct. But in the other, we have a constellation of symptoms like cyclothymic disorder, which will include alternating episodes of minor depression and hypomania that might be precipitated by a stressor. But the abundance of symptoms in that other column should help differentiate from an adjustment disorder, where you're really just saying, depressed mood or anxiety and or disturbance of conduct. Other questions about the bipolar and related disorders? All right, so Edith Brennan presents to you and you diagnose bipolar 1. There's no evidence of psychosis. By the way, point prevalence, lifetime prevalence of psychotic features in someone with bipolar 1. So what percentage of people with bipolar 1 will experience a psychotic symptom or psychotic symptoms at some point in their life?
30,
50%.
50%.
50%. Right. Depression, unipolar depression, major depressive disorder, 10 to 20%. Right. So it's more than double. Right. Which is again why, even though she may have been admitted for depression, the psychotic symptoms in the infant side that she demonstrates is more likely to be due to a bipolar disorder that initially presented with a depressive episode. All right, so you diagnosed bipolar 1, and you're going to get together a treatment plan here. So what are some thoughts in terms of what you want to provide to Edith?
Yeah.
Like lithium. How about lithium? All right. So in providing an informed consent and full disclosure of this medication, lithium, what are you going to tell Edith about potential side effects?
She's planning to get pregnant. Could cause birth defects.
Okay. Do we have a date or a year around where Edith was in the hospital? I know they show the record. Anybody pause it and geek out and,
1858.
yeah. So prior to lithium being discovered. Yeah. So unfortunately, yes. Huh?
So they would just put her in an asylum then?
And then just, yeah,
Yeah.
custodial, yeah, we have to make sure that we discuss the teratogenic potential, risks and benefits, especially women of childbearing years. Let's say that she inquires, tell me more. I have to know more about the actual risk. What numbers, epidemiology are you going to present to her? By the way, what is it that you're presenting to her? And she's not like the word, she doesn't understand what teratogenic means.
Birth defects.
Birth defects, okay? So doc,
It's pretty rare.
pretty rare. 50-50, doc. Less than 50-50, so 40%, doc. Yeah, it's low. It's like it's between, yeah, it's less than 5. Yeah, less than 5%. Yeah, and that was the next question, is Epstein's anomaly, right? Which is the atrialization of the right side of the heart. So again, we have to make sure that we discuss these side effects, but Epstein's anomaly is rare. In some reports, it could be 1 to 2%, but certainly less than 5%. All right, what else do you want to do here? What other side effects or adverse effects do you want to discuss?
Tremors, GI upset.
So straightforward side effects, right? So they provide a side effect profile, all right? What other issues pertaining to the medication?
Lower seizure threshold.
When? The toxicity, right? We often discuss this medication, lithium, as having a narrow therapeutic index, which is a very clever way of saying that the therapeutic dose is actually pretty close to the toxic dose. right? So we're gonna have to check blood levels, right? And you better tell your patients that you're gonna be checking blood levels probably on a quarterly basis. Because you want to make sure that that blood level comes back somewhere between 0.4 maintenance dose and 1, with 1.2 kind of being the upper limit of normal where you might be seeing toxic syndromes or signs of toxicity. What are some other signs of toxicity? Doc, tell me if I'm getting to 1.1, what should I be looking for? What's your answer?
You also have like nephrogenic diabetes and stuff.
Mhm.
So you're new.
Yep. That's definitely a big one. Thirst and polyuria. Others? Mental status change, delirium, impaired gait, shakes, tremor, all part of the syndrome of lithium toxicity. Patient comes in with symptomatic lithium toxicity. So they present with tremor, seizure, mental status change, delirium. And you check a level and it is greater than 1.2. Single next best step.
Stop or reduce the dosage.
All right, so they're not due for the next dose until tomorrow. So we're just going to observe them overnight.
Some antidote.
There's some antidote. What is the antidote called? Hemodialysis. Right. That's a very common shelf question, hemodialysis. Because of the size of the molecule, activated charcoal is a no-go here. Right. This question?
No, I was just gonna offer the wrong answer, so. Good thing you went first.
Any other information you'd want to provide on lithium here? One of the side effects that I do want to, again, mention is weight gain. That's got to be discussed. Unfortunately, a lot of the FDA-approved medications in the treatment of bipolar will induce weight gain and most times significant weight gain. So diet and exercise should be part of the biopsychosocial treatment plan for every individual treated for bipolar disorder. Another issue pertaining to this medication is how long am I going to take this, doc? What's your answer?
Likely forever.
Yeah, indefinitely, right? If lithium is stopped, there is about a 95% chance the individual will have a future mood episode. And there is zero predictive value in identifying that 5%. Right, so, and therefore any clinician, any prescriber should never enact or employ in their treatment plan a trial off the medication. The only time that would even be considered would be during pregnancy. And again, that's not without risk. Any questions about lithium? And then, again, somehow tied to side effects, so we'll mention it kind of as a separate issue. Routine lab monitoring in addition to the lithium level. Yep. So BUN creatinine because of its nephrotoxicity. The other thing is that it's cleared renally, right? There's really not that many medications in psychiatry that are cleared renally. They're usually cleared through the hepatic metabolism. So if that creatinine shoots up, it means that you're going to have impaired metabolism, right, and potential toxicity. Usually we get a sodium because a lot of the things that affect sodium are going to affect the lithium salt. So we usually get a sodium level. We usually get a calcium level as well. Calcium level. There are case reports in which there is lithium-induced hypercalcemia, and one of the proposed mechanisms is that lithium can activate occult parathyroid adenoma. So we don't get routine scans, but we do get annual calcium levels. Questions on lithium? All right, any other medications to consider here?
Nitrogen.
Yeah, so let's just talk about the anti-epileptic drugs, right? So that's the AEDs, including lamotrigine. Lamotrigine is FDA approved for the treatment of maintenance, and does have clinical evidence that it is effective or more effective in averting a future depressive episode, more so than a future manic episode. Lithium is the opposite. Lithium is actually better, more effective in averting a future manic episode than depressive episode. But that's Lamictal or lamotrigine, and there's several others that are FDA approved, including valproic acid and carbamazepine. Only because carbamazepine appears on exams more than other AEDs for the treatment of bipolar. Let's talk about this and the medication's potential adverse effects, which include teratogenicity again. And then similar to valproic acid, what is the teratogenicity of carbamazepine or Tegretol? Yeah. More prevalent, less prevalent than those teratogenic effects of lithium. More, yeah, about 10%. Yeah, and because they're neural tube defects, you'd think that maybe giving doses or mega doses of folic acid during pregnancy would help with that incidence, and I have not seen that consistently proved in literature. So have them take folic acid anyway for obvious reasons, but I'm not so sure it's protective. Other thoughts about carbamazepine before I begin to pimp you on it?
Oh, sorry.
All right, here's the well, again, her name is Edith Brennan, and you're starting her on carbamazepine. She is of childbearing age. What are you going to tell her about the use of this medication? And as a result, what do you recommend? Yeah. So okay, Doc, what do you mean? Like, what are my options?
So, the ID.
Any other options? Condoms? Any other options? Okay. All right, so which one of these three options should Edith choose and why? You guys have to take out notes from your other rotations. They can't believe you're discussing this stuff on psychiatry. IUD? How come IUD?
Is she forgetful? Like, did she forget to take OCP?
Let's say no. Maybe condom, okay, so why is that also correct? Here's the easier question. I was trying to nudge you guys. Why are OCPs the wrong answer here?
Hormonal issues with are you referring to like progestin or no?
Carbamazepine affects blood levels of the hormones.
How?
If
It
we're
lowers
50.
It lowers their effectiveness, right?
And exactly how is that? It's an inducer. I think it's a 3A4 isoenzyme resulting in the OCP being cleared. So they're going to be taking it daily. Let's say she is not forgetful. Let's say that she is actually very compliant. Doesn't matter. All right. The OCP, because of the induction effect of 3A4, is going to be metabolically cleared. It's not going to be in her system. She's going to get pregnant. Maybe that's what happened. Now, 1800s, I don't think carbamazepine was there. But that's something I definitely have to discuss with your patients. All right. Okay. So let's say that she chooses the barrier method. And she's actually doing fine, and there's discharge planning. So she's actually feeling much better. You go to her room for a morning rounds. Discharge planning looks maybe we're going to keep her over the weekend, and we're looking at a discharge date for Monday. You walk into her room, and she is floored lymphatic. What happened? No contraband, no drugs. You quickly check nursing notes. She's getting her carbamazepine. Very common test question.
She's angry and stuff?
No, she's manic.
Oh, I thought you said mad.
No, I'm sorry.
No, you're-
It's the afternoon on Friday. I tend to speak very rapidly and
No,
start
I think
cutting,
that's
cutting
my
off syllables.
To change the dosing.
No, no, the dose was optimized and her last, she just had again, this is a Friday, so she just had a level on Monday. It was perfectly normal and has been normal with the last 3, 4, 5 times we checked it. What's the next best step? Next best step is to check the level. This medication is an autoinducer. It induces the very isoenzyme that is metabolized through. Okay, and one day it could just happen. Right, so a very common test question. When you get the urine drug screen back and it's completely normal, next best step is to check that level. Because even though it was just checked earlier in the week, as an autoinducer, it's metabolized the carbamazepine and it'll be at a subtherapeutic level, resulting in a manic episode. Or being dead. In addition to lithium, which is in a class by its own, in addition to the anti-epileptic drugs, including carbamazepine, the other class of drugs that are often used to treat bipolar 1 illness or bipolar illness are the antipsychotics. The predominantly the second generation or the atypical, but there is one conventional first generation antipsychotic that is FDA approved. Just in case it gets asked on an exam, what medication is that? And I'll give you hints. It's the first antipsychotic discovered. Chlorpromazine. And chlorpromazine does have an FDA approval for the treatment of mania. Otherwise, you're going with the second generation atypical antipsychotics. And along with the anti-epileptic drugs and lithium, you've covered the pharmacotherapy of bipolar. Questions? All right, we can move off Edith now. Any other characters, subplots in Mama you'd like to discuss?
We can talk about the kids. I guess it's interesting to me how they were kind of left at different ages and then the developmental trajectory that put them off. I don't know if anyone's seen the movie like Room or read that book. That's kind of what it reminded me of. It's like that kid was trapped in some underground basement. And when you're not interacting with society, that changes obviously how you grow up. And I think it's shown in this movie with the kids.
Yeah, they bonded and they're imprinted and again, Victoria is able to overcome that. But Lily simply is not, hence the very unfortunate ending of this movie.
And I guess I was thinking also because Victoria was older when it happened, that like she didn't miss as many developmental milestones maybe as the younger one.
Oh, definitely.
Yeah.
Mhm. Yep. I mean, certainly more when you're on your pediatric rotation in psychiatry, but my gut says is that there might be a question or two on your psych shelf dealing with milestones. So it's probably something if you've already taken peds to go back and just refresh on prior to your exam. Yeah, wouldn't hurt you. What would be really interesting is if in the sequel, these two sisters met up in their late 20s and how that meeting would look,
Mhm.
right?
Could be, isn't there something that like if you aren't exposed to language by a certain age, then you'll never be able to develop the skills to speak?
I have to look that up, to be honest with you. It sounds,
I think,
Plausible?
yeah, I can't, there's definitely a name to it, maybe I'll look it up. But I was thinking about that too.
yeah, again, that would certainly focus on Lily,
Mhm.
yeah. Final thoughts? good. All right, so I'll be posting this on Twitter probably later tonight, but next week's film will also be next week's 31 Nights of Halloween film, which is Paranormal Activity. All right, so we just ramp up the creepiness just a little bit more. Get really everybody in the mood for October. So we'll be definitely chugging on all cylinders by then. Any final thoughts or questions? All right, we'll leave it here. Thank you.
Thank you.